get started. So welcome to Facebook Live, Why Do I Have Thyroid Symptoms Even Though My Lab Tests Are Normal? Part 4, okay? And so today we will be covering what's called peripheral utilization aspect of thyroid disturbance. So, okay, cool, thank you, Morgan. And so, like I said, the goal today is to carry on where we started with parts 1 through 3. And so let me just say first that for those of you who don't know me, like I said, my name is Dr. Joseph Smith. I'm a chiropractic neurologist, and I practice in Fairfax, California. And however, we advise and have the opportunity to help people from all over the world here. And so we get a lot of the same questions over and over again because we see chronic conditions, and there's some kind of basic things in chronic conditions that we see a lot. And one of the things that we see a lot is thyroid symptoms and thyroid patterns that have not been resolved. And so part of the reason that I'm creating these videos is so that there's a resource for new people that come to us, and also for people that are just online searching. So if you happen to know somebody with chronic fatigue and unresolved autoimmunity, digestive disturbance, constipation, depression, inability to lose weight, even though they're exercising, eating perfectly, that maybe they've been told they have thyroid symptoms and their lab tests are normal, just let them know that this information's out here. Well, it can be found on our Atlas Health Facebook page, and also I started a YouTube page called Dr. Joseph Smith. And so please share this information so that they can have the ability to make an educated decision about what's going on with their life. Most of this information, not all of it, has been taught to me by a great mentor, Dr. Datis Kharrazian, and he wrote this book, Why Do I Still Have Thyroid Symptoms Even Though My Lab Tests Are Normal? And so that's where I got the creative title for this course from. And so if you're looking to learn more about this information, I highly check out that book. I think there's a second edition of it out now. And so this is part 4 of a 5-part series. The next part is going to be on autoimmune thyroid. So without any more further ado, let's get started on the information. I just want to give my disclaimer at this point. And so, like I was saying at the start of the broadcast, my degree is a chiropractor. And so I'm not authorized to actually diagnose, treat, or cure thyroid disease, okay? And so it's really important that I state that if you are taking a thyroid medicine, I'm not telling you to stop taking it, okay? I'm not telling you one thing or another about your thyroid medicine. If you feel you have a thyroid issue, get some labs done and have a medical doctor look at that and tell you whether you have a thyroid disease or not. And if you have a thyroid disease, the only way to actually treat a thyroid disease legally in the United States is to treat a disease, any disease, is through a medical doctor. So what we're going to talk about here is for folks that have had labs done and they've been diagnosed with a thyroid condition, and maybe they're taking medication, and maybe they're not feeling great still, okay? And so the idea behind this series is to help people understand thyroid hormone physiology and to go over lifestyle factors and nutritional support factors that can make a difference to support the underlying physiological breakdown that is contributing to the thyroid symptoms. As we've discussed in previous videos, thyroid symptoms really can stem from either primary hypothyroidism, which is one of like the 24 patterns of thyroid disturbance, or secondary hypothyroidism, which is the rest. So primary hypothyroidism most commonly needs prescription medication. Okay, so for the rest of the patterns, there might be some lifestyle or nutritional support factors that can help improve thyroid function without calling that treating thyroid disease. So I just want to be really specific and clear on that so that those that are watching out there realize that I'm not false advertising myself as a thyroid specialist, okay? So here we go. To kind of bring us back up to speed where we're at, we talked about the different thyroid patterns as it relates to physiology. So let me just tell the story again really quickly. We know that the brain has a little sensor called the hypothalamus that senses the circulating amount of thyroid hormone. Okay, and then the hypothalamus projects to the pituitary gland And if thyroid hormone is low, it tells the pituitary gland to release TSH. Okay, if the thyroid hormone is high, it tells the pituitary gland not to release TSH. But what ends up happening is the thyroid gland then makes T4 and T3 based upon this. Now, it does so by taking 2 iodine plus 2 tyrosine and making T4. It uses an enzyme called TPO. We're going to talk a ton about TPO next time. Okay, that's one of the most common areas of autoimmunity. Okay, if this is attacked, that autoimmunity is called Graves' disease. If TPO enzyme, the worker bee that glues those things together, upregulated by iodine, is attacked, that's called Hashimoto's. And you can also have an attack on something called the binding globulin, which all hormone that's made is bound to a binding globulin. That also could be Hashimoto's. Okay, now, we talked about, in the first module, the second module, I should say, we talked about 5 things that can disrupt the hypothalamic pituitary thyroid axis, okay? And so let's just review those very quickly. The first thing was related to a prolactinoma. And so for those of you who haven't had a chance to watch that video yet, it's embedded in our Facebook page. It's part 2 in this series. The second thing would be elevated cortisol. The third thing would be elevated cytokines, meaning chemicals that white blood cells use, often seen in chronic infection or autoimmunity. The fourth thing would be related to dopaminergic projection, so other parts of the brain firing into the hypothalamus. And the fifth thing would be related to serotonin. And so for those of you who that just seemed like really fast and it was too much to keep up with, I would check out part 2 of this series. I go into that in great detail. Okay? Then we talked about what happens after the thyroid hormone is made. Thyroid hormone T4 goes to the liver and it gets converted to T3. It gets converted to something called reverse T3 and something called T3S and AC. Okay, these ones go to the large intestine and they get converted to T3. Okay, now they're all bound to a hormone or to a protein, a transport protein. Okay, and so we'll talk about what that means here in a second. We talked a little bit about that in part 3 of our series last time. Okay, and then once it's all converted, it goes to the tissue. So let's just review the 5 things that can actually disrupt this conversion process, okay? Because there's an enzyme called 5'-deiodinase that takes care of this process, okay? And so again, that's in part 3 of this series. So if you happen to miss part 3 video, there's a whole bunch of information on that. But basically that's when T4 looks normal, but T3 is low. And so that conversion takes place in the liver or in the bowel. And low peripheral circulating dopamine and serotonin can cause that, but that's going to be a different mechanism of the brain dopamine and serotonin. High cortisol can cause that. High cytokines can cause that again. A deficiency of cofactors can cause that. So that would be like things like that might be missing if we have malabsorption or if we have a restricted diet, okay? And then if that conversion isn't taking place, then T3 is not available to activate the tissue, okay? So here we are sitting here. We have the tissue with a thyroid hormone receptor waiting to receive T3. Now, in general, the body uses T3 for most stuff. It does use T4 for some other things too, but we're going to focus primarily on T3. Okay, and so once T3 gets made, it gets brought over here and it goes to the tissue, and then it releases the bound hormone, so that cleaves off. Okay, so now it's called a free T3, okay? And so the free T3 activates the receptor, and then that cell now has a chance to make energy, and the DNA gets stimulated, okay? Now, these patterns are the most interesting patterns, I think, in the functional model, and the reason is this. You could have the most perfect conversion, you could have the most perfect TSH in production, you could have the most perfect free versus bound level of thyroid hormone. But if the receptor is not working, nothing will happen. So this is truly the person that comes in and they've done everything. They exercise, they eat right, they watch their diet, they make sure they're not eating inflammatory foods, they're sleeping at night, they've tried taking all these different supplements, to help with thyroid conversion or to help with thyroid cofactor issues, and nothing is working. They've actually, they may be taking prescription medicine, and the medicine made their levels look normal on their lab, but their lab tests are normal, but this receptor just is not working. It does not work. And this person generally is very tired, okay, because none of the cells are making energy. They may have like slow healing. They may get sick all of the time, and they're slow to get better. They're slow to have wounds heal. They're probably constipated. They might be cold all the time. Their hands and feet, they could be depressed. Pretty much everything that could be slowed down is slowed down. Okay, and it's because that receptor does not respond. Okay, by the way, I will answer the questions a little bit later on. Okay, all right, so basically, what's going on here? Okay, why doesn't this receptor respond? Why does this guy not respond to T3 and therefore no energy is made? It's an unhappy cell, okay, because the receptors just do not respond. Okay, so in the literature, low vitamin D, low vitamin A are two cofactors, or two big reasons why these receptors don't respond. Now, vitamin D and vitamin A are fat-soluble vitamins, okay? So the simple answer is to say, okay, well, let's just give this person vitamin D and vitamin A. But the appropriate thing to do as a clinician might be to say, well, why are they deficient in vitamin D? Do they have a lack of intake? Do they have a lack of absorption? Do they have an overutilization? So on and so forth, okay? So anybody with low vitamin D or low vitamin A, we have to say, okay, a lot of people that I know get out in the sun plenty in California, and they still have really low vitamin D. And I can tell you vitamin D that's low is almost ubiquitous. And this is not in the literature. This is my personal feeling on it. I just feel like so many people have so many infections and immune upregulated things going on that they're just burning through their vitamin D very, very quickly, okay? Now, every cell on the body has a vitamin D receptor. So when vitamin D is low, every cell can be affected negatively by this, all right? Now, the other thing about vitamin D is that it's a fat-soluble vitamin. So a lot of people are fat phobic. They just won't eat fat. They won't. They've heard that fat will help them gain weight. And so a lot of people that I see that have issues losing weight are trying to like not eat any fat so that they don't gain any more weight. And so what ends up happening is they don't get their fat-soluble vitamins like vitamin A and vitamin D, and their thyroid receptors don't work as well. And now they've created a vicious cycle where they have hypothyroidism causing them to not be able to burn fat and lose weight. And they have poor malabsorption or poor absorption and malabsorption. So the vitamin D that they're naturally getting through food or vitamin A just isn't happening. Okay, so you can see how it's one thing just to say you have low vitamin D. It's another thing to investigate the underlying issue. Okay, the other thing with low vitamin D is that if the person has malabsorption, it will show up in other areas in their history, and it will show up in other areas of their labs. So, for example, the person may have lab tests suggesting malabsorption, and they may have symptoms suggesting malabsorption. So we might not want to just give them vitamin D. We might want to give them a sublingual or a transdermal version of vitamin D so that even if a person with malabsorption can get those levels, okay? Now, it's the same thing with vitamin A. Most people that are vitamin D deficient, when we started running labs on people for vitamin A, often come back low in vitamin A, and they're also low in vitamin K, and they're low in vitamin E. And so the issue is a matter of intake and a matter of absorption. And a lot of people with low thyroid function have malabsorption because T4 and T3 are very, very necessary for healthy digestion and absorption in blood flow to the intestines and also healing of intestinal tissue and repair. So we can see how you get this vicious cycle of malabsorption compounding a nutritional deficiency, compounding a receptor site pathology that creates another thyroid problem that makes everything worse. Okay, and so here's the person that has perfect thyroid levels, they have perfect thyroid conversion, or they're taking a thyroid medicine and their thyroid labs were low in T3 or low in T4 and they've got up to the perfect levels, but because this receptor does not have vitamin A and vitamin D docked on it, okay? So vitamin A would go like here, vitamin D would go like right here. Now that receptor doesn't work the same way, and therefore you get all these expressions. So that's the concept of vitamin A and vitamin D. Okay, now I'm going to do a little video on this because I mentioned this earlier on my page this week, and I just got to attend an awesome seminar and work at it, do tech support and help other doctors with their complex cases over the weekend. And the seminar was functional endocrinology, and it was about hormones. And we know that with hormones, including thyroid hormone, one of the pillars of thyroid hormone dysfunction is essential fatty acid problem. So if you're not able to digest and absorb, or if you're not eating enough fats, then basically your body has very little chance of functioning well. One of the mechanisms is because fats are anti-inflammatory or pro-inflammatory, and if you're not absorbing any fats, you're going to end up in a pro-inflammatory state. And the secondary issue, or another primary issue related to that, would be you're not getting your fat-soluble vitamins, and therefore your thyroid gland and other tissues that are starving for fat-soluble vitamins aren't going to work. Okay, so one really awesome sign that you have an essential fatty acid problem is A, your stool is floating, you're not absorbing your fat very well, or you have light-colored stool. B, you take an Advil or an aspirin and you feel better. Or C, you eat fish oil or you eat a fatty food and you start burping pretty quickly afterwards. Okay, if any of those things are happening to you, odds are you're not absorbing your fats very well. And in order to remediate this vitamin A and vitamin D issue as it relates to thyroid function and all of your thyroid symptoms like constipation and depression, we're going to need to deal with this essential fatty acid absorption issue or utilization. Okay, so that's like a very, very, very important concept. And I have to tell you that it's not just as simple as throwing some thyroid cofactors at this or throwing some vitamin A or vitamin D at this. We really need to address the underlying essential fatty acid or fat malabsorption issue. Okay, now some people with a fat malabsorption issue actually just have an issue where they have an overabundance or an underabundance of healthy, normal microflora in their bowel, and that creates an issue where they have a malabsorption just from that. Okay, some people have raging celiac disease or non-celiac gluten sensitivity, so they have inflammation at the level of the small intestine. They've destroyed their brush borders, which means the little enzymes that allow nutrients to get into the small intestine aren't working, and so they have malabsorption for that reason. Some people with essential fatty acid malabsorption have a gallbladder issue, okay, where the gallbladder just has this thick, pasty bile, and there's just really not much function coming out of there. And so that could be the issue, and that's usually secondary to liver stress or a low-fat diet or high trans fat or high alcohol lifestyle. And then you could also have a stomach issue where you're not making enough stomach acid, and therefore the small intestine, the gallbladder, and the pancreas, none of those things are going to work right secondary to that. So that needs to be investigated. Okay? So just to say a person is deficient in vitamin D or vitamin A based on a lab test and they have thyroid symptoms, and to only give them vitamin A and vitamin D leaves a lot to be desired, and it's unlikely that a person's just going to respond to vitamin A and vitamin D as a standalone therapy for a secondary hypothyroidism on this pattern. It's going to require those other aspects of physiology are addressed through lifestyle and nutritional support. And I can tell you my experience has been it works really well. People start to feel a lot better when these things are addressed. And it's really looking at the basic foundational aspects of physiology instead of just trying to treat a condition, which I actually legally can't do anyway, with a prescription, or just to say you're treating a disease process with nutrition, which actually isn't accurate. Okay, so there's a drug protocol for every condition, and then in the alternative model, there's like a symptom-based nutrition approach to every condition. But then in the functional model, what we try to do is look at the underlying physiological breakdown as to why these things are happening and support lifestyle and nutrition and brain function and the rest to bring that physiology back online so that they can start to function normally. Okay, so let's move on to another pattern of peripheral thyroid receptor site utilization problem. Okay, so we talked about vitamin A and vitamin D being low. Another aspect related that can screw this guy up here is something called high homocysteine. Okay, homocysteine is something that the liver normally makes, and it's a normal process, but then we're supposed to take it and turn it into something else right away. And what happens is there's a lot of people that are inefficient at doing so. We convert protein in our liver to homocysteine while we're trying to make something else. And so sometimes, like, people that eat a lot of meat, maybe too much meat, and they're just not able to keep up with all the conversions, they're getting deficient in cofactors, can have higher homocysteine. That's a really unlikely cause or unusual cause, but some people do feel better when they eat less meat. And if they don't have low stomach acid and they just feel better when they don't eat as much meat, one of the mechanisms might be higher homocysteine. And that's my clinical experience. I'm not sure you're going to find that anywhere in a book, okay, or in the literature. Now, we've all started to hear about these MTHFR genetic defects, or genetic, what are called SNPs, okay? And what that means is that that person is inefficient at a particular metabolic process called methylation. Okay, now we need to methylate homocysteine into something else to not have it accumulate. And so what ends up happening is homocysteine gets high, and then basically it comes up to the receptor and it starts trashing it. So imagine, like, if you had a dish for, like, TV on your house, and then it got like a solar storm or something, and the solar storm sent all the radiation from the sun, and it started messing up the dishes because it interfered with the signal. That's kind of like what homocysteine does. Homocysteine goes to the receptor, and it's not like it's a deficiency like vitamin A and vitamin D, but it outright creates an inflammatory or an irritant at the receptor. Now that receptor doesn't respond very well. Okay, now homocysteine does some other things. It's actually a neurotoxin, and it can contribute to anxiety. It can contribute to blood vessel disease and contribute to cardiovascular disease. So some of the symptoms of elevated homocysteine include low thyroid symptoms, but also anxiety or depression, poor circulation, and like some issues related to heart and cardiovascular function. Okay, now elevated homocysteine, like I said, could be related to poor methylation. Okay, decreased methylation, which takes place in the liver. Okay, and poor methylators often have a family history of cancer. So methylation is how we repair our DNA. One of the first steps in the progression of cancer is damage to the DNA. And then one of the second steps, which is called, damage to the DNA, is called oxidative stress. And then once the DNA is damaged by oxidative stress, it mutates a little bit, or it gets a little ding on it. And then methylation is supposed to happen to repair that DNA before it replicates. And so when methylation doesn't happen, damaged DNA replicates, it accelerates the aging process, and can contribute to activation of pro-oncogenes. Okay, so can you see how important it is to just do a homocysteine test for just about anybody? Because that's a really nice screening procedure for a methylation issue. And if a person has poor methylation, not only they may have increased risk of expression of low thyroid symptoms, which accelerates the aging process, it contributes to poor quality of life through things like depression and low energy, but also that this person with high homocysteine may have poor methylation, and with a family history of cancer, if we don't support that with proper nutrition, may be at an increased risk for cancer. That's a really big deal, okay? Now, methylation is also one of the ways that we detoxify estrogen. And I will tell you, we all know this, we are swimming in a sea of estrogen. There's over 80,000 different chemicals in the environment right now that mimic estrogen in the human body. These endocrine disruptors are also called obesogens in some cases, meaning this, they contribute to obesity. And one of the mechanisms is through causing cytokine elevation, which means the immune system starts freaking out on them, and also through its effect on thyroid function. Okay, so it affects the immune system, and it affects thyroid function in a really nasty, terrible way. Okay, so we need to have a way of clearing out these haptens in our environment, and a really nice way to do that is to support methylation. Okay, so in our office, when we see people with thyroid symptoms and they, don't have a thyroid disease that would require medication, and so we can support the underlying physiology, or they do have a thyroid disease and they are taking medication, but they're still having symptoms. Now we can put them on some nutritional support to support their liver and to support healthy peripheral utilization of thyroid hormone, and all of a sudden their thyroid hormone, which is already in their system, works better because this receptor will respond to it now. So that's kind of a cool thing where medicine and nutrition can actually work together, which is kind of what we need, right? So that's kind of cool. Another thing about methylation and thyroid disturbance is that people that go on, for example, SSRIs, which is like Prozac, okay, or they go on something like the pill, those things tend to deplete methyl donors, meaning this. Methylation is a function of the liver, and then methylation requires something called methyl donors to convert homocysteine into a non-toxic substance, okay? And so sometimes people, when they go on other drugs, you notice they gain weight. So like a girl might go on the pill and she'll gain weight, or a guy might go on Prozac or something like that and he'll start gaining weight. And one of the mechanisms of that is that it depletes the body of methyl donors. Their methylation sneaks down, their homocysteine sneaks up, they get peripheral utilization issues with thyroid hormone, and they start gaining weight. Okay, so that person, boy, wouldn't it be cool if we just supported them with methylation so they got the best possible physiological response to their doctor prescribed prescription and possibly could diminish some of the side effects of that medicine through that mechanism. Isn't that cool? Okay, so that's a little bit about elevated homocysteine and its relationship to peripheral utilization, okay? Now, the last two things that I want to talk about, we've already talked about at length in the other two patterns, okay? So the last two things that can really affect peripheral utilization in the literature is, which means this, making this thyroid receptor not work very well, okay, are elevated cytokines, which again, cytokines are chemical messengers that the white blood cells use to communicate, okay? And then also elevated cortisol, okay? So cortisol is supposed to be highest in the morning, supposed to be lowest at the end of the day, but when we work out too hard, or when we don't work out enough, or when we don't get enough sleep, or if we get really stressed out at work, or we get stuck in traffic and we get ticked off in traffic, or if we eat too much sugar in one meal and have an insulin surge, our interleukin-6 might go up, which is a cytokine, which will mess this up, okay? And then we might get a cortisol response. Now, a really great indication you have a cortisol issue is if you're having short-term memory loss and weight gain around the middle, okay? You might notice that your memory just isn't super hot, and you might notice that your sense of smell is affected a little bit. And the deal is when you have an issue with elevated cortisol, you might have a sleep disturbance where you can't fall asleep at night, or you fall asleep but then you wake up and can't get back to sleep. Or you might have a sleep disturbance like you wake up in the morning and you just cannot get going. You feel like complete crap. Maybe you have low cortisol, maybe you have high cortisol, okay? But if you have high cortisol in the morning, exercise that's intense is contraindicated, okay? And that could exacerbate this entire pattern, okay? So there are ways to objectively measure high cortisol, okay? And I like to use saliva testing for that, because saliva testing you can easily do throughout the day, and saliva testing gives us a nice tissue level, and saliva testing doesn't require a needle, which will just naturally elevate cortisol at the site of a needle, okay? So those things can be measured. Now, high cortisol will also do what? Remember, we said high cortisol messes this pattern up here, and high cortisol messes this pattern up here. So the reality is that we can see people with high cortisol, and odds are they're going to have more than just this. High cortisol, which means stress, due to overtraining, undertraining, bad relationship, stress at work, family stress, not enough sleep, too much sugar, not enough food, malabsorption, or a severe thyroid issue causing an energy production issue, autoimmunity, infection, will cause cortisol to go up, and cortisol will mess this up, it'll mess this up, and it'll mess this up. And there's actually a way to quantify that and qualify that with history and exam, and that's what we're doing here. That's what we're talking about. So how do we deal with high cortisol? Okay, well, a lot of people will take adrenal adaptogens for that, and a lot of people will take things that protect the brain, like phosphatidylserine for that. All right, and that's a nice Band-Aid for some people. For other people, it doesn't work because some of those adaptogens can stimulate the immune response. So if they're having a cytokine issue from overactive immune system, taking an adrenal adaptogen that exacerbates the cytokine issue might not work for them, okay? But none of those things, phosphatidylserine and adaptogen support, will actually fix the underlying cortisol issue long term. We have to get to the underlying over or under training. We have to help them understand the need for sleep. We have to talk to them about triggers related to food. We have to identify the underlying relationship stress or work stress, and we have to help them compensate. We also have to help them by getting real with them about what's actually going on. And when I say we as clinicians and them, I mean you all as patients. We need to really get real with you and just say, it's not just going to be about taking this supplement and making this dietary change. Okay, for some of these thyroid patterns and basically any chronic condition, whatever strategy was employed for you long-term, just it hasn't been working. So what you really need is to get in there and have a doctor that will look at everything and then say, look, this is what's working, this isn't what's working. And you may say, I've been this way my whole life. Well, that's fine, okay? For example, what am I talking about, right? So like the person that says they get up and then they don't eat for 6 hours because they're not hungry. That person may have really, really, really high cortisol. And they don't eat for 6 hours, okay? And that high cortisol issue is driving all of this, okay? And so we need to come up with some sort of pattern of activity, a pattern of eating, a pattern of supplementation, and also talk to them about eating right away, even if they don't like it, to really fix the underlying issue. Okay, so I just want to emphasize enough that we can identify these patterns in the literature showing up in people's histories, but we really need to do the work of changing the underlying physiological pattern with lifestyle. And if we can do that, we can see the physiology shift and we can see these awesome changes. Okay, so a cortisol test can help us figure out where you are on a map there. But really the work after that is to figure out what the heck is driving it and for how long. Okay, and there's no one supplement or one exercise or one brain modality or one type of therapy or one practitioner that does a singular mono approach that's going to take care of that in most cases. Okay, unless it's just an acute thing. Okay, the last thing I want to talk about, and I'm kind of running over time here, is related to cytokines. Cytokines, again, they're messengers the white blood cells use to communicate. And a lot of people with peripheral utilization issues, when we look at things like a white blood cell count, their white blood cell count will be elevated or chronically low. And if it's elevated, generally they know they're kind of in this acute infectious state, so they might be sweating at night. That would be a really good indication. They may have a fever. They may have swollen lymph nodes, okay? They may have a sore throat or a cough, or they've had pneumonia recently, and they know it, okay? They know they're not feeling well. And so, but we've identified that they're fatigued. We know that when people are often sick, they're fatigued. And part of the reason that is because their thyroid is shut down because of this cytokine interaction on the peripheral receptor, okay? Where it gets a little tricky is when a person has low white blood cell count or like functionally low white blood cell count due to either autoimmunity or infection. We have to identify where the infection is. Is it in the bowel? Is it somewhere else? Is it in the brain? Is it somewhere else in the body? Is it viral? Is it fungal? Is it mold? Is it bacterial? Is it a parasite? Okay, we can identify that with follow-up testing. Some of the tests that we like to use here at Atlas are like medical diagnostic labs, and we like to do stool testing. I like to use a lab called GI mapping for metabolic solutions, and then there's another company called Genova that I like to use sometimes. Depends on what the history is, and there's subtle differences there. A person with autoimmunity can get that diagnosed with, again, history. They have a family history of autoimmune disease like rheumatoid arthritis. Do they have a family history of celiac disease or thyroid autoimmunity? Do they have fatigue or eczema? You know, stuff like that going on. And if those things are going on, plus they have a low white blood cell count that's chronically low, plus an elevation of a type of white blood cell called a monocyte, which means there's tissue inflammation happening and it's just trying to gobble it all up, that would be suggestive of autoimmunity. And we can do things like Cyrex testing to find what are called predictive antibodies, okay? So that's kind of a segue into our next course in this series, which is going to be part 5, dealing with autoimmunity. So I'm not going to spend too much time on that, okay? But just to summarize, when a person has a peripheral utilization issue, often their thyroid levels are perfect, or they may have two of these other patterns going on if it's a cortisol and cytokine elevation. And there are ways to actually support that person nutritionally to help improve function, and they start to see things like constipation go away, their energy come back, their ability to lose weight happens again, and with exercise and diet, they're losing weight, and it's a pretty cool thing. So unless anybody has any questions, I'll just say that what we're going to do next time is we're going to go into the cytokine issue at length as it relates to autoimmunity, and so we'll get more into the specific types of immune testing that we can do in part 5 of this series, which is why do I have thyroid symptoms even though my lab tests are normal, specifically related to Hashimoto's and Graves' we're going to get into next time. If you need to get a hold of us here, you can email me at contact@atlas-health.net or call Lindsay at 415-459-4411. And let me just see if there's any questions. Do I hear about thyroid and heart palpitations? Yeah, that's something that we hear quite a bit. And so one of the areas of the body that's most sensitive to energy fluctuations is the heart, okay? And yes, we're definitely going to be saving this in our Atlas Health Facebook page, so you can just go to the video section. And also, if you go to our YouTube page, Dr. Joseph Smith on YouTube, it'll be posted there as well, so you can share the link with people not on Facebook. Okay, so back to the question about heart palpitations. So that one of the areas that is most sensitive to energy disruption in the body is the heart, because the heart has some of the highest concentration of mitochondria, which are energy-producing organelle. So people that have thyroid symptoms often have these little heart things that are going on. So that's a very common thing that I see, yes. Now, another thing about heart palpitations is that the right vagus nerve will control the rhythm of the heart function, and the left vagus nerve will control the rate of heart function. So sometimes we see elevated heart rate, sometimes we see low heart rate with a weird rhythm. And so sometimes that can suggest some of those neurological sequelae. And so if a person has a thyroid pattern, for example, of secondary hypothyroidism due to pituitary suppression, and they're getting some of these heart symptoms, we might want to look at our bedside neurological exam to see if we can identify any serotonin or dopamine neurons that are not working properly, that are contributing to a pituitary dysregulation that is causing a secondary hypothyroidism with all the concomitant fatigue and some of the specific heart chief complaints. So hopefully that answers that question. Let's see, any other questions? Okay, well, hey, I appreciate the thanks. You're welcome. And the best thanks for me would be to share this video with people that you feel would like a little bit more information about how to make good decisions about their health, because so many of these questions come up over and over and over and over again. And just about every case that I see in this clinic from all over the world has some sort of secondary hypothyroid pattern that needs to be physiologically supported in order for them to heal. So this conversation is something I have day in and day out, and it would be great to have people be aware of this information, you know, sooner rather than later, so they can start making a difference for their own health and their family's health. So thank you for your time. I'll be posting another announcement as far as part 5 of this series. I'm also going to be doing part 3 of the why do I have SIBO and why do I have unresolved SIBO and digestive symptoms even though I've done every diet and supplement. Okay, so part 3 of that's coming up as it relates to GABA. So again, thank you for your time, and we'll see you next time. Bye.